Hi, everybody. Thank you so much for coming. I'm Dr. Greg. I'm the director of the Global Institute. Today is Global Institute Medicine Grand Rounds. So we're just absolutely thrilled to sponsor this Grand Rounds. As you know, Global Institute does a lot of our global health outreach and commitment to social justice. So we have someone who epitomizes all of those ideals here today. So visiting us from Boston, but I'll let Jen take it away for formal introductions.
All right, it is my pleasure to introduce Dr. James O'Connell joining us today. Dr. O'Connell received his master's degree in theology from Cambridge University in 1972 and his medical degree from Harvard Medical School in 1982, after which he completed his internal medicine residency at Massachusetts General Hospital. Upon graduating, he began working with homeless individuals as the founding physician of Boston Healthcare for the Homeless program, which today serves over 10,000 homeless individuals annually. With his colleagues, Dr. O'Connell also established the nation's first medical respite program for homeless persons and designed and implemented the nation's first computerized medical record for a homeless program. During his career, Dr. O'Connell has served as the National Program Director of the Homeless Families Program of the Robert Wood Johnson Foundation and the U.S. Department of Housing and Urban Development. His work has been published in numerous journals, including the New England Journal of Medicine, and he has received several honorary degrees and awards, including the Albert Schweitzer Humanitarian Award in 2012. In 2015, he published a book, Stories from the Shadows, Reflections of a Street Doctor, and more recently in 2023, his work was chronicled by Pulitzer Prize-winning author Tracy Kidder in Rough Sleepers, Dr. Jim O'Connell's urgent mission to bring healing to homeless people. Please join me in welcoming Dr. O'Connell.
Thank you so much for that kind introduction. There's a part of that my mother doesn't let me talk. There was 10 years between college and medical school, which maybe a dinner over scotch or something we can talk about, but she won't let me talk about it publicly. Although they were the best years of my life. A real treat to be here, by the way. I've long admired what goes on here at your medical school and the hospital. Going back to when I first visited, I've only been in Miami once before in my life, I'm embarrassed to say, but I came down and visited. It was Camilla's house many, many, many years ago. And so what was going on in the community was really spectacular. So my hat is off to you. And I feel like, you know, you should be preaching to me rather than me preaching to you. So it's an honor. But let me give you a couple things. I dug out some slides, old slides and new slides, just to give you a little sweep. I'm realizing I have to live with the burden of it's almost 40 years I've been doing the same paid job. And I once promised myself, as you can imagine, I'd never do anything for longer than 2 or 3 years because you get stale. So this is an attempt to justify why I'm still doing the exact same thing. But I got started, I was a resident in medicine at Mass General, getting really old. And I was going to become a palliative care physician. I wanted to go do a fellowship. And my chief of medicine, and I was mentioning this to Dr. Weiss, who was an endocrinologist named John Potts, grabbed me one time. It was March of my senior year, and the city had just gotten a grant from the Robert Wood Johnson Foundation to try to organize care for homeless people who at the time were in the early 80s were starting to flood our emergency rooms. And we were trying to figure out how do you go out and take care of them before they came. So they did that. You know, the city got the grant, and the grant was given to mayors, by the way, because an interesting thing about homelessness, which I'm sure happens all the time, is that the problems are going to have to be solved at a national level. We're going to have a complete change in how we do housing and how we do healthcare, you know, mainly giving people rights to both of those. And what happens though is that the day-to-day problems of homelessness end up on the mayor's desk, not the solution money. So mayors have to deal with it all the time. So the foundation gave these grants to the mayors. Our mayor was forced by the foundation to sit with a bunch of homeless people and figure out how they wanted to be served. And I show this picture because this is a later version of most of those people are now not around anymore, but this is what has evolved into our consumer advisory board. But they were the ones that set the tone for what we want to do. And I'm still a resident, so I wasn't doing any of this. And the other thing, a couple things they said was they had to be involved in the planning and implementation of any of our programs, which has been a tall order. And several of these folks were on our board of directors, and that means they hire and fire us. Kind of interesting twist. But I wanted to be sure I attribute it. Here's what they said. Let me make sure I know how to do this. There. So this is what they came up with in 1984, okay? And they decided it was all about social justice and not about charity. So we couldn't use volunteers for the first 5 years because they thought that smacked of charity. We couldn't use students because they felt they were going to be guinea pigs. Really interesting. All the things that we had decided I had my friends were going to volunteer. We had students all lined up and they said no. And I thought that was cruel. But what they wanted was continuity of care. And they wanted that content. This is literally their words or what they came up with. They wanted that to go from shelter and street to the hospital. So there's a lot in that, like how do you make sure people are cared? Let me give you an example. They knew when they got sick and they ended up in a hospital, that's when they felt most frightened and most sort of, what's the right word, most stigmatized. So they wanted, like back in those days, they wanted their own doctors and nurses to be involved in their care in the hospital, but then not abandon them when they go back up, but then follow them outside. And our job was to go out to find them on the streets or in the shelters, and that's kind of became the thing. They also, by the way, really interesting, made us work in teams. And I was, you can all take this where it's coming from, but I thought it was because they were very smartly asking for multidisciplinary stuff. But it was all about continuity because I decided when I got asked by the chief of medicine, I said yes, because you have to say yes to your chiefs of medicine, or if you value your career. I'm only kidding, but you know what I mean, sort of not kidding, but kidding. But I said I'd do it for a year because I wanted to do something to give back. And I'd gone to school in the 60s and had a lot of lingering social conscious issues. So I decided I'd do it for a year. But the people that I went to serve hated that idea because they said, look, you're going to come here, we're going to get to know you and open up to you, and you're going to hopefully earn our trust. But then you're going to get up and leave after a year and not stick with us. So they were really interested in continuity. So they made us work in teams. So that I've never had my own panel of patients. I always worked with a nurse practitioner, a physician assistant, and now a psychiatrist and a recovery coach and a social worker. So that if any of us leaves, each homeless person has the rest of the team that they know. Then we had to be on call 24/7 to them. This was a requirement. And that someone they knew had to answer the phone. Kind of interesting thing. I kind of wish we could do that today. I can't get my doctor to answer his phone. Anyway, so that was a team thing. And the last thing they said was this thing about respite care, which we had never heard anything. We didn't know what it was, had no idea. To them, though, it was a result of their anger toward all of us in the doctors, particularly in the hospital, who would take care of you while you're sick, but then send you back to the shelter or the street when it's time, you don't need the hospital anymore, but you're way too sick to walk around all day and try to live in a city that has maybe one public bathroom. So they wanted a place where they could go and be cared for, since they didn't have a home to. So that's what that was the beginning of respite things. But I just wanted to show you that because that comes from homeless people, not from us. And we would have done it very differently, as I'm sure you know. So I had to leave, just to give this, I was looking at this slide the other day because one of the oldest slides I have, but I finished my last job during residency was the senior medical resident in the intensive care unit. And that was June. So July 1st, I go down the street to a shelter clinic. And I kept thinking, that if many of you who are near the end of your residency, if you're here, you get this feeling you can handle anything, that, your ego can barely fit into this room. And I figured, how hard can a shelter clinic be? We'll go down there. So I went down the street. They had this great clinic that had been run by nurses who were actually volunteer nurses from one of the local emergency rooms who had decided to go down to the shelter and take care of people before they had to go to the emergency room. And they, at that time I was joining them, they were on the cover of the American Journal of Nurses as the only independent nurses clinic in the country. I don't know if we have any nurses here, but if there are any nurses, this is really all about nursing, except I would say they were not happy to have a doctor. Okay. So I walked in and they, it's my first job. And I'm paid, by the way. I've never been a volunteer. This is a paid job. So I went down there and I had to cope with the fact that they weren't ready for anybody like this. And then they taught me about everything I know. And I could go on and on. This is a picture of a man having his feet soaked in the clinic. And for 2 months, that's all they allowed me to do. I could only soak feet. Took away my stethoscope, took away everything. And they said, you got to learn to listen and you got to learn to take time and you got to learn to earn trust. And that's what we had to do. It was really wild. And I can promise you, I wish I had gone on to my oncology fellowship at that point. And then I'm trying to establish that I know what I'm doing. I want to earn my credibility. And this man comes in Uh, and later became, his name is Jack. He became a patient of mine for years after. But the staff brought him into the clinic. And not even the nurses, this was staff out. This, by the way, Pine Street has 800 people sleeping in it. So it's a big, crazy shelter. And the clinic is really wild. And they brought him in. They said, look, doc, he doesn't look very well. And we've known him a long time. He just doesn't look right. And so I said, oh, let me take a look at him. And he came in and he's looking at me and saying, doc, they're making a big fuss over nothing. I feel fine. Just let me go. And I looked at him and, can you guys hear me okay? I can tell you, it's okay, good. And I looked at him and I was very proud of myself because this was scabies and I hadn't seen that much scabies in medical school and residency. This was scabies, what that? He also has a basal cell in front of his ear, and if you're doing physical findings, he's got pectus excavatum, and he's smoking too much and drinking too much, but he doesn't want to talk about that. And his vital signs are totally normal. And I listened to his lungs, and in the craziness of the shelter, they sounded perfectly clear. But any of you are still medical students, I did not do, I did not do whispered ventriloquy or the things I probably should have done, but I didn't do that. I listened, you could hear air all over the place. So I told the staff that, and Jack wanted to get out of there. He wanted to just get back out to the clinic. So I said, he looks, maybe something chronic is going on. He really needs to maybe not smoke so much and not drink so much, but he's not interested in that. But I don't see anything acute. And so remember, I'm trying to earn my keep. So the next night I said, but if he's still bad, bring him back. And they brought him right back the next night and said, doc, he is not right. So we have an old x-ray machine, and this was his x-ray the night after I had cleared him, okay? So you can see me coming from the hospital thinking I'm God's gift to the shelter, and I missed this. And it turns out if you listen to those lungs, you can, in a shelter setting, there's air moving everywhere. So it sounds pretty normal. And because he had this, what turns out to be multi-drug tuberculosis for months, he had no fever, no signs of, he had a smoker's cough that he'd had forever. But it was a mind blower. If you look really carefully too, there's a right upper lobe pneumothorax on this x-ray. So this was TB. It was INH and strep resistant. It was 1985 in a shelter, and it became the index case of 60 people coming down with acute TB in the shelter, and 40% of everybody in the shelter converted their PPDs from negative to positive. So I'm sitting there thinking the ICU was a piece of cake. How do you take care of 60 people who need 4 medicines every day for 18 months? And because Dee Dee's here, I want to say the first time I ever met Paul Farmer was when he came down as a student and was fascinated by the fact that we had not near very close to the medical school, had this multi-drug resistant organism. And what we ended up doing, I was stuck. We couldn't treat this unless we were part of a larger community. This became part of the MMWR. I'll skip that. But the nurse at the shelter, whose name was Barbara McGinnis, after whom she taught me everything I know and after whom we've named our program, she's sitting here on the left with Yoshiko, who's a nurse practitioner who was on my team. We were together for about 15 years. But this was the TB room. Those are, for those of you who've never seen it before, in the pre-digital age, those are x-rays. And the medical student's job was to carry those, which weighed about 5 pounds each, from place to place. But we had to figure out, where were these people? I'm sorry. Oh, I'm sorry. We had to figure out, where were those people and how do you get them the medications? And I had no clue, but the nurses and the staff pointed out that most homeless people, even though it looks like chaos, had a relatively ritualized routine. So we could figure out where they were, and then we could get on our bikes and go do them. So when I think of street medicine for us, we were already doing shelter, clinics in the shelters, but now we had to get out to the street. And I remember this is what we had to do, get on our bikes and go out and give people their medicine each day. This is Mark on the right, who's a social worker that was on the team with Yoshiko and me, and Ursula, who's a public health nurse. So we had to learn to work with the city and the state Department of Public Health, the nurses and the outreach things. And, in a tribute to good friends, I was a bartender for a long time before I went to medical school. And I had a friend who was a bartender at JJ Foley's, which is about 2 blocks from Pine Street. And once Pine Street, you don't have to be sober. It's a wet shelter, so you can come in any state. You just can't drink once you're in the building. So a lot of the men, and turn out 7 of the men who had TB, used to stop there before they came to the shelter, have the beer or beers, whatever they're having, and then would come in. And then this bartender, we give him the medicine, and he would give each of them, give them the medicine, make them take it before he'd pour the beer each day. So he did the entire treatment for 18 months for these 7 guys. And there was a coffee klatch in South Boston where 4 other men were treated. Interestingly, that would be illegal to do now, but back in 1985, that was kind of the way you could do it. But it was a learning experience for me that this is a job. If any of you are doing this, it's really a community job. You need the whole village if you're going to be able to take care of it. You know, someday, interestingly, Paul Farmer used this he got involved in this and used this exact same thing down in Peru when they went down and did the TB thing in Peru. So it was interesting that an inner city TB outbreak could teach you how to do it in a third world setting. And the nurses, the brilliance of the nurses was, how do you catch active TB when there's 800 people sleeping in a shelter? And you know what they did? And I'll never forget this. They just made a cough log. Okay. And this is a crude picture of it. But what they would do at nighttime, we would have one of us would just hang out for a couple of hours in the dormitories, and you'd target who was coughing. And the next day, those are the people you'd go get. And all of the cases of active TB we caught by cough, not by PPD and not by X-ray. So that was kind of brilliant part of the nurses showing you what to do. This was the earliest picture I have of our respite program, where we were trying to honor what the homeless people wanted, which was to come up with a place they could come to after they came out of the hospital. And the governor, it was Governor Dukakis at the time, gave us 25 beds in the corner of a 100-bed shelter. And we just, you know, started out not knowing what we're doing, but we had 24-hour nursing, and the doctors were on call. We were there 18 hours a day and then on call the rest. And it was for all sorts of different things that, you know, none of which would surprise you. People that, as you send them out of the hospital, you know, they need to continue their antibiotics. Their diabetes is out of control, stuff that wouldn't work very well in the shelter. People coming out after surgery, chemotherapy, radiation, things like that. And then about a month after we opened that, in September of 1985, this man came into our thing, and he was the first homeless person back then to be diagnosed with AIDS while living in the shelters. So this was the first case we had of it. So we have an outbreak of tuberculosis, totally unrelated to immunocompromised folks. And now we have AIDS. And those of you who were around back then will remember initially we didn't even know what caused it. We had to recognize it by these opportunistic infections that otherwise normal people were getting. And then we realized we had no treatment. So for the first several years till AZT came along, we had no treatment, and everybody died these horrible deaths from opportunistic infections. And it was our little respite program really became an AIDS and TB unit back then. And I say this to you just to show you that there are waves of pandemics that really take the wind out of your sails. So I'll never forget, every patient I had essentially died from AIDS back then. And when the protease inhibitors came around 11 years after this picture was taken, it was like a miracle. And so to this day, I think it's hard for me to get mad at pharmaceutical companies, because you can come up with treatments that keep people from dying. There. This is now our respite program has evolved over these last 40 years. And we now are in this building, which is right across from the emergency room at Boston Medical Center, which is the busiest trauma center in New England. And we have 104 beds, and it looks like a step-down hospital. And I can show you a few things. So we do a lot of end-of-life care thing. It's sort of satisfying an old need for palliative, because as you know, most homeless people would have lost their contacts with family and friends and relatives. And when they're dying, they're pretty much alone. And loneliness is a huge issue for us in every which way. But this is an example just in our respite program. We have a couple men here who are dying. One's 84, dying of a neurological cancer, and the other one is 37, half his age, and dying of metastatic lung cancer to his brain. But we found that in that respite program, we can sort of marshal end-of-life care where people are dying among friends and around people who care about them. But the cost to the staff is really intense. And I could go on and on about that. We also have, I just want to, I didn't know of all the millions of things. So at respite care, what do? We have a lot of people who, are on chemotherapy, on radiation, things we used to admit people to the hospital for in the 1980s. Now it's outpatient, so we can take care of them. People that get surgery, almost all surgery, common surgery now is day surgery. When I was in 1985, when I was at MGH as a senior, you stayed 4 weeks on average if you had a cabbage. Okay, 4 weeks. Now it's about 3 days maybe. And most surgery, hernias were a week, gallbladders were about 10 days, cataracts were about a week. Now that's all done as outpatients. And in that sort of really improved, all the things that improved with that, homeless people got lost. Where do they go? Who takes them there? Who picks them up? Who does a pre and post op? So we've had to do that, a lot of that at our respite program. And I could go on and on, IV antibiotics, et cetera. But the other thing we do that I wanted to show you is we do get frostbite. And I don't know how much you've seen that, but just one quick thing on frostbite, because it's what we kind of live with all winter. This is a man who's outside during what we call the polar vortex of several years ago. He was stayed out the whole time with not really shoes. He wrapped his feet in sort of clothing. And then this is Dave Munson, who's our amazing young doctor who has been with us now for 12 years. And Dave and his wife actually made a contact with him and convinced him to come in, but he wouldn't come in unless he could have all his stuff with him, right? One of the things we always torture about is people who are homeless and living outside particularly carry everything they own with them. So when we want them to come into the hospital or something, they have to bring everything with them. And that becomes an issue. So we have this whole elaborate thing of making sure we can take care of stuff that they come in. But this one was pretty radical. We had to get a flatbed truck. I'm sorry about the quality of this picture, to go get one of his 3, but what he called buggies, so that we could actually get him to come in and get cared for. We had to store them down in the basement of our building, which doesn't have that much. The interesting thing is there was more stuff moving in that than there was not. So it was really interesting. But he came in and we took off his shoes for the first time. And these were his feet. And this is one of our nurses sort of just slowly taking off. And check this out. This is what he was walking around in. Okay. And I don't show this picture except in medical worlds, but this is what we always, I mean, this is the quintessential thing about homelessness that kills me. This is completely avoidable. When it happens, it sheds parts of your body. So it's permanent loss. So this man's going to lose he stayed with us for almost a year after that, while that foot auto amputated. You don't want to do surgery. You want to wait until it'll save as much as inside. But I could give you the whole scenario of that. And he is now back outside walking on that stump. It's really quite extraordinary, but he comes into the clinic now all the time. Shifting gear now, because he leads it into it. My clinical life now is mostly with people who are living outside. And in Boston, they turn out to be this really, I think, kind of wonderful, but characteristic subpopulation of the homeless population. For example, tonight in Boston, 95% of everybody who's homeless is going to be in a shelter. So we have an elaborate shelter system, and only about 5% of people are going to be outside. And those people could have a bed, but for all sorts of complicated reasons, that's not something they can tolerate. And it goes from they can't be around another 500 people to the most vivid one I had that made me stop asking people, we can't say why you choosing to be outside, because they'll look at you like you're crazy. They're choosing not to go into a shelter, choosing not to go. But if you offer an apartment, they'll go right into an apartment. But I was seeing one man one night when it was like -5 degrees. We were trying to coax him in just for the night to get him out from under this bridge. And he looked at me and he said, "Doc, I appreciate that, but," he said, "when I go into Pine Street," he said, "I can't tell which voices are mine." He said, "When I stay here under the bridge, I know they're my voices and I can handle them." And then you realize it gets very complicated. And so we don't really ask that anymore, but you can see their things. So back in 1986, early 86, the Department of Public Health in Massachusetts, because we had seen so many people that were dying were the ones living outside. That small group of people living outside tend to be have the highest death rates. So they gave money to the shelter Pine Street to have this van go out every single night. It goes out from 9 p.m. till 5 a.m. every night of the year, and has been doing that now for 38 years. And it's run by these really remarkable, if there's heroes in this story, here they are. These are folks that are paid to run the van. They mostly have experienced homelessness at some point themselves. Many are in recovery. They come from all sorts of backgrounds, and they ride each night serving soup and sandwiches and blankets. I had tried, by the way, when we had these things about what to do with the van, I thought, of course, it should be a medical van. And our homeless people at our board went like, "Are you kidding? We don't want to see a doctor or nurse at 2 a.m. We want a sandwich or a blanket or coffee." So that's what the van does. And as long as I buy the coffee for the staff, I've been running on that a couple nights a week for the last, since whatever it is, 40 years, 39 years. But it's like this. So, I won't bore you, but these are the cold nights. This is this is actually in Northeast, and when the temperature is about 0 degrees, still 100 and some people sleeping outside, just like this man is on the steps of one of our famous churches. This is a woman who sleeps on this bench. I took this last Christmas and she's been sleeping on this bench all the time I've been there. We've never been able to coax her off. This is in Boston's North End, right at the holidays. And then we do that at nighttime. And then we realize you can do a lot at night, but you really need to be out during the day. So about 25 years ago, we really started, pushing being out in the daytime as well as at night. And this is a picture I love because it's our team visiting this man who lives in this alleyway. And it's, Becky, who's our nurse, and the woman next to Becky, next to the man, is Katie Coe, who's our full-time psychiatrist on our team. And then Katie Swanson is our nurse practitioner. But the cool thing of this and the fun thing for us, luxury, is we get to all go together. So you don't have to refer one to another. So that the ability to integrate care like that is just a gift. And if I were recreating a healthcare system, I'd make that mandatory. The other thing we had to learn, which I'm sure you guys have learned, is that, the nurses challenged us. We used to try to always get to know people and lure them into the clinic where we could do whatever you think we could do. But they said, what goes on inside the clinic that you couldn't do somewhere outside or somewhere at a McDonald's? And it turns out about 75 or 80% of everything we do, think about it, in your clinic, you could do somewhere else with the right support. There's some very private things you can't do. But this is a woman who's 84. She refused to come to the hospital with her heart failure, except when she was an extremist. And this is Dave again, who's an internist like myself. And we decided, with a lot of coaxing from our nurse practitioner, that why don't we just take care of her heart failure there at the train station where she lives each day? And she was perfectly willing to let us examine her, draw her bloods. We could change her medications. We could weigh her. And so we worked closely with the heart failure folks to manage the heart failure there. And it turned out it worked for about 10 years. Okay, she went to the hospital a couple of times with really acute pulmonary edema, but most of the time was under full control. And we learned a lot from that if you've got the right support, if you can work with a specialty clinic, but do the outreach on for it, you can do amazing things outside. She's now had to go to a nursing home when she got sick from other things though. And this is Jim Bonner, who's the first full-time psychiatrist in our team. I've learned, by the way, over time, just to share with you, it's always great if you can have a full-time team, even though most of the time you have to cope with people like myself who could only be there a little bit at a time. I shouldn't say like myself, but others. But when you have full-time people, it means when I see somebody in any kind of clinical setting, the psychiatrist is always there, and it's the same psychiatrist who cares for the same people. So anyway, this is Jim, and he used to run a community mental health center. He's that was sponsored at Harvard Medical School. And then he decided for the last 10 years of his career to come work with us as a full-time psychiatrist. And he was astonished by how many people he had once called treatment resistant would be perfectly happy to talk to him at McDonald's. And this is a woman who we all got to know that did all of her psychiatric care, her therapy, and his prescriptions and stuff he'd meet her at this one McDonald's that was near where she lived, and he had a renaissance in his life. So I now believe there's a lot we can do creatively for the people it's not for everyone, for those who have trouble coming in. The other thing we learned is we looked around, and most people who lived on the streets weren't getting any preventive care of any kind. You could argue even, why should you do it? But we learned as we get to know people, they were more than willing to say yes. And I'll give you the most radical example. There was not a single woman that we met on the street. By the way, in our town, there's 3 men to every woman on the streets chronically, but we did not know a single woman who had had a pap smear or a mammogram in their memory. And at first we would ask them if they could do that. Nobody would say yes. But as they got to know our team after 2 or 3 years, we learned that they would usually say yes once they trusted the provider. And then we learned when they come in for, an admission for pneumonia, make sure we do our pap smears and mammograms while they're there. And it's radically changed it. So our outcomes now are about the same as we get in our other clinics. And this is flu shot season, where Jill, who's our physician assistant at that time, was with Pat Perry, another doctor of ours. And we do flu shots. We just pick a couple days during the year, just bring flu shots out and give them to everybody. And we rarely get someone to say no. It's really kind of interesting. As long as the person giving it to them is somebody they know well. We also learned, and a theme I would love to share with you, is why I don't know what you're going into, or what you're already into, but this is a game for all of us. It's not for just emergency people or internal medicine or family medicine people, but we need specialty care because the leading cause of death for us, if you leave drug overdoses aside for a minute, by far the leading cause of death for us is cancer, and second is heart disease, third is lung disease. So we are constantly in need of good specialty care that's going to work with us. And I'll give you an example of that down the road. But this was a man who had been I saw him under a bridge one day, and he had been in the emergency room 5 times in the last 2 weeks, really angry at emergency room because he had this itchy rash that he was convinced was scabies, had it treated several times, but he wasn't getting any better. So he let me take this picture. It was the first time I had taken a picture with a phone, I remember. So date this, whenever phones came out. And I didn't know, if you look at, I don't know how good you guys are at derm. I'm not as good as I should be, but that looks a little bit like Norwegian scabies, if you've ever seen Norwegian scabies. The problem was, as I looked at him, he's got these nodules, if you see, up on his neck. Let me see, these nodules are up on his neck, and those aren't scabies, you know, so something else was going on. But I didn't know what it was. So I sent this picture to Ernesto Gonzalez, who is the chief of dermatology at MGH, who had been coming doing clinics in our respite program for a long time. And I sent him the picture, and you know, dermatologists can do a pretty good diagnosis about 80% of the time with a good picture. So I had also trained, he had been a teacher of mine when I was doing medicine. I had done a rotation in dermatology. So he sent me back this kind of a rump email, you know, like, we went through this a million times, you should know this. Does anybody know what this is? Because I did not know. Okay, and you can make me feel better if you don't, but if you know it, you can embarrass me. But it turns out it's nummular psoriasis. Okay, and he just said, here's what you do to treat it, you know, and a few weeks later. So this man thinks we are the best doctors that ever existed. Okay, and it was our first sort of specialty visit under a bridge. So there's all sorts of immense potential for doing things and working more closely together that I would share with you. And then just to end the continuity thing, because this is all my theme of continuity. The longer you do it, I think the better your outcomes are going to be, the better your return on investment. So this is Jen Nunes, who's now been our PA on our team for maybe about 10 years now. And we went through hell with COVID, as did all of you. 40% of everybody living in an 800-bed shelter got COVID. And we were at our wits' end. Our respite program became essentially the COVID unit for homeless people in Boston and environment. And then when the vaccines came along, it was kind of a miracle for us because it really, you know, brought the ICU visits down. But how to get, you know, folks on the street, this is particularly vaccinated. So we were really worried, but we finally got the shots, and in that refrigerated thing, you can see that Jen's dragging around. We would bring the shots to people. And do you know that we know of only 2 street people who said no to the vaccine? 2. And so it's like 98% of them said yes. And it was this kind of revelation. They said yes, mostly because they had seen how sick all their friends had gotten, and they wanted to work on helping them out. And the other thing was, it was somebody they knew saying, hey, can I give you this shot? It wasn't like a clinic somewhere where they didn't know what was going on. So I've long thought they have a lot to teach us. And this, by the way, is a park on the grounds of our hospital where the homeless people hang out. So when you look though at the street population, we have done some studies that if you factor out, you know, we know that homeless people in most cities die at about 4 times the rate of somebody who's not homeless of the same age in that city. Look, those studies have been done all over. But when you look at a street population in a place like Boston, that rate triples. So they're 12 times more likely to die of someone the same age. So living on the street conveys yet a higher premature mortality rate than the shelter, which already conveys an unacceptably one. So we've been trying hard to figure out what to do with that. And I'll give you one example here. This is a man who I had seen for years. And I, you know, have these Irish heritage. So if you ever need any help on squamous and basal cells, I can tell you everything about them because I have about 35 of them. But he had a squamous cell on his face, a basal cell carcinoma on his face. And I would look at him and talk to him. And as I got to know him, and he said, oh, doc, it's okay. And he would pick it off. That's what he could do. He could pick it off. And I kept saying, and he's a really sweet man. He has schizophrenia, reads a book a day. And then eventually it got to be this, and I'm sorry about the quality of this picture, but he came in, he said, okay, doc, I think we got to do something. It's not getting better. And I don't know if you can tell, but this is now a basal cell that has evolved a little bit well, it's all basal, but it now involves its entire scalp. Okay. And we had to bring him into plastics to do surgery. He had a flap, you know, had to remove all of that, got a flap. And then he was one of the early people we were able to get into housing. And this is him we're visiting him in one of our home visits, and you could see what's happened to his face. But by that time, it was metastatic to his brain and into his spine, and he died of metastatic basal cell carcinoma. I'd never seen it before. Apparently it is, you may have seen it, but it was like, talk about the most preventable cancer in the world, and we lost him. So that's what happens if you can't get to that. I'm going to finish up with a story of somebody who just gives an example of, I don't have a thing. I want to make sure I'm not good. So in these last few minutes before we do questions, just an example of why I think, what you're doing and what you're starting to do here is so critical. And I think for this small group of the people that are really without the stability of homes and have lived through all of the insults of bad schools and poverty and racism and all that, and end up on the streets or in the shelters, the continuity of care you can give is really invaluable. So this is Michael, who I met the first night I was on the van back in it was January of 1986. And he had been on the streets for a while. He had grown up in the South somewhere on a cotton farm. And he had been abused by whoever was taking care of him. And the state took him and sent him to Massachusetts to live with relatives, where he ran into even more abuse. And by the time he was 14, he was on the streets. And he's a sweet man, has huge street smarts, but never learned how to read or write. Okay, so just to give you a little background, 25% of the men who are on the streets of Boston cannot read or write. So when you think about what are the determinants of their situation, they go way back to adverse childhood events, to trauma, sexual, physical neglect as kids, and to being in bad schools and bad foster care. And those are things that we, happened so far back that we don't have much we can do to change it. But anyway, Michael was delightful. We see him on the streets all the time. And one day he came in, did I do this right? So one day he came in and we were following for all sorts of things, but we have a clinic at MGH that he came into one day, and he said, Doc, and he had these huge nodes over both of his clavicles, and he had metastatic prostate cancer. And so we brought him up to the, to the cancer unit, and there was this amazing team that began to take care of him. And we brought him over to our respite. This is where respite programs become really important. And this is him. And he taught us this lesson of, when he was given nothing in this life at all, nothing. But when you gave him anything or cared for him in any way, he was so appreciative. So this is him at our respite program that's Julie, by the way, if Jessica's still here, with one of our nurses, and he's just so happy. He's in a bed, he has 3 meals a day, and even though he's going through chemotherapy, he can handle that, right? And he does really well. He goes into remission. And I'm going to tell you a story that's now I'm short-circuiting a story that plays out over 8 years. So when he was done with the chemotherapy and he had no place to go, we have a step-down respite program over in this building. It used to be our old respite. And he went there so that he could stay to be sure he was okay. And, and it's a sweet spot. He went there, and I took this picture because that's when I found out for the first time that he was a fanatic lover of animals. And so when we have these, therapy dogs that come in all the time, and he was all over it and really thrilled. By the way, what I didn't say very well is his spot, he's like many homeless people. He had a spot downtown at a Starbucks right near the Boston Common. And that's a pretty wealthy area. And he's in his own inimical way. He knew everybody coming in and out there, remembered people's names, their kids' names. And he was loved by everybody down there, even though he couldn't read or write. But anyway, so after that, we were able to get him, for the first time in his life, he's now 60 years old. We were able to get him working with the city stuff into a housing program. And so he's signing his lease here. We love this picture because he's like so happy. He's going to have his first apartment, and his cancer's in remission at this time. And for some reason, I don't know why I cherish that photograph. And then before he would go in though, so we went to take him to his apartment, he had to go to the animal shelter and get a cat because he just had to have a pet. So he gets his cat, and he's like jubilant, goes into his apartment, and it's like a miracle. It's just terrific. This man has been on the street since he was 14. Now at age 60, finally goes in, and he has an animal. And then we realized, I wanted to share with you, I don't know if I have a picture here. I want to share with you what we learned from our the people on our board of directors who are homeless, is that we thought once people got housed, we could then say, great, we get them into the healthcare system there and we'll go back to take care. But they beat us up about the continuity. They said, look, if you've been our doctors or our team for 20 or 25 years, just because we go into housing, you can't then say we can't take care of us. So we've had to learn how to do home visits as a street team doing home visits. But this was one of the visits to Michael. He was upset here because he needed us to move the couch to straighten out the rug. And we ended up doing much more physical work than we did medical work most of the time. And then he would do things like he'd call me up, you know, because we promised we'd always be on call 24/7. He'd call up and I'll say, Doc, same old place, which is this great little sandwich shop, closes in about half an hour, but I need a meatball sub. Can you get me one quick? And you debate that, like, am I being abused here or what is going on? But we would get it for him and then he would just be so appreciative. And that was his life, that's what he looked for and enjoyed. So now we're frame shifting a little bit. Now the cancer recurs several years later. Now it comes back very aggressively. And this is when we realized we had to get back in touch with the hospital, get him ready for chemotherapy again. And we went to get him, and this is Becky, our nurse. Would have to pick him up each day to bring him over for his 6 weeks of daily chemotherapy. And this is him being a character. This is true. But before we could take him up to his chemotherapy, we'd have to bring him for breakfast at the hospital. And he would always have these exact same thing, this, French toast with about 15 things of maple syrup on it. But look at him, he's just thrilled. And he's the first person I ever went to see. I went up to see him he's in the chemotherapy suite, and I went up to see him to be sure he was okay, and he was getting plugged in. And there's a flat screen TV, 2 nurses around him. He's got a snack in front of him, and he smiles this big broad smile. He has no teeth to smile with, but and just says, Doc, it does not get any better than this. And I was like, this is, I'm going to learn how to appreciate life in a different way, because that's what he was doing. But and then it gets really bad, and we now know he's on really at end of life care. So he's only got, at the time I took this picture, maybe a week or 2 at most to live. And he's now in agony because the cancer has gone into his bones, and he really needs much more medication than we can give him at home. But he won't come in because of the cat, right? So there's all these complications that go on. I'm realizing, God, this is not what I trained for, but this is what you've got to figure out. So Jen, our nurse practitioner, our PA who was with me when we were doing the home visit, said, hey, Michael, I'll take the cat home. And she still has a cat to this day. And then he went, okay, once the cat was okay, he could come into the hospital. So he came in. This is the end of the story. So goes to the hospital, and we get him on all these medications. And I decided I was going to go see him on the next morning. And I said, do you need anything? And he goes, you know what, Doc? I need a Big Mac. He said, but no lettuce. I don't know if any of you tried to get a Big Mac with no lettuce. It's not easy, okay? And I went, oh, this guy's dying. He wants a Big Mac, no lettuce. So I tiptoed into his room. He looks like he's about to die. And I said, hey, Michael, I've got this sandwich. You really want it? And check this. This is my last picture I have of him. He sits up, smiles. He can't eat the sandwich, but he can smell it, and he can do all the stuff you can do. And he's just ecstatic. My time is up. He's ecstatic. And I had to step back and realize here's a man who's dying. He died the next day. He's dying, he's in agony, but he still learns how to get joy out of stuff, and how little we do that ourselves. But the moral of the story is how great it is to be part of a person's life over time in many different situations. So I think there's huge things we can all learn from all of this. That's our current board members, and I think that's all. I could go into, what it means to do the housing and stuff, but I think I'm going to stop here and ask for questions, and thank you all for letting me be here. So, can I say one thing about Paul, by the way, since Dee Dee's here? So I used to, so we became friends, but Paul was friends to the universe, as you know, Mel. But we used to be on panels together. And he's the first person that made me feel like it was okay to do the work we were doing. So he would introduce me. We'd get up, and Paul knew the world. He would get up and he'd say, I want to introduce you to this friend of mine who's never gotten more than a mile from medical school. And then he'd go on and talk about Peru and Russia, Rwanda, all these magnificent things. At the very end, though, he'd always come back and say, do you realize that a mile from our medical school, and this is Harvard, he sees the same health disparities we see all over the world. So when I think of global health as so intimately involved with urban health, we have so much to learn from looking at both. And it's a total pleasure to be here. So any questions, I'd love to answer.
Dr. O'Connell, I can say it's a true honor to see an angel in our midst. There's lots of questions and lots of things one could ask, but maybe I could start by in addition to congratulating you on a career that many of us would emulate, and I know it's not over yet, but I want to ask, often in medicine, whether we're doing the type of work you're doing or whether you're an oncologist or an endocrinologist, the question of empathetic distance and how these patients affect our lives when we leave their presence is sometimes hard to sort out. And here's somebody who is on call 24/7, some like yourself, and someone who has followed these patients for so many years. How do you cope in your personal life with your family and so forth? How has this affected you and how do you cope with it?
That's the kind of question that makes me want to run under the table. Okay. So, but it's so poignant. I think when we first, very frankly, try to maintain, we used to call it work-life balance. Now I think it's work-life integration, how you figure out how to do that
Wellness.
is wellness. It's absolutely critical. And we did not do that very well. So when I think I came out of residency back in the days when, residency was 100 hours a week. And when we went down to 90 hours, it felt like a vacation, right? But we never had any balance. And at the time I wasn't married, didn't have any kids. So there was TB, AIDS, it was impossible not to do it all. And I've spoken to lots of friends about that. And so you get involved in that at the price, I think, of your own personal stuff. And so how to draw that back and get some balance is something we talk about in our program now all the time. So I would never, for example, let any doctor or nurse or social worker do what we did early on. It's not sustainable. And now working in a team, we've learned is really fabulous because we have so much death in our lives of the people we're caring for that it's devastating when someone like a Michael dies, often from something preventable. But when you're working in a team and you've got ways to share that, and then I think we've learned also, I didn't get married till relatively late in life and incredibly late in life had a kid. So now I have another important part of my life that I realize, oh my God, if I had had this child 40 years ago, I'd be Cherokee now. But I think I love the emphasis now throughout all the training programs. I'm sure you have it here on maintaining your wellness, maintaining that integration. And I'm not a good example to say that.
It seems like therefore, but the grace of God go I when you see these people on the street, and it could just be one small event in your life that changes everything to the point where we ourselves could be homeless. And I don't think we appreciate that often enough.
I couldn't agree more. And if there's a lesson I've learned, and we share that with all of our team now, is first impressions were always completely wrong. If you get to know someone over a year or 2 or 3, you start to see someone emerging who's living a life of incredible courage, not someone who, you might have thought otherwise. And I think we've been around long enough to know that we've got hundreds of stories I can share with you of somebody was just one thing went wrong and the whole cascade of events happened. So I think we all have to have that, I think, an honest realization that people we're caring for are going through something any of us could go. They're no different than we are.
Any other questions or comments for this amazing speaker? Yes, please.
Question. What you're talking about is, I know approved to the bean counter these days in hospitals that it's worth funding programs like this. Has it been proven? I know there have been some studies done, but hasn't been done enough to be able to prove that it's worth doing a hospital like Jackson here, do an outreach to the homeless. Would that really save them money or not? Many people don't know what this. I'm harsh.
Oh,
Sorry. Camillus. You talked about Camillus.
I know you. I know you. It's okay. I didn't know whether you were twisting the dagger here or not. No, if I'm really honest, we have tried every which way to get the data to show, for example, we have a respite program. Hospitals send people to us all the time, and I know that's saving the hospitals incredible amount of money. But can we prove it? No, it's so the healthcare reimbursement thing is so complicated. So no, we can't really prove it. And then we have clinics, for example, in all the shelters in Boston. Our program now is clinics in 40 shelters in Boston, all of them, where we have doctors and nurses. And how many emergency room visits are they saving? I would love to know, but we don't know because we don't have a control group to show. So the short answer to that is it's rarely been studied in depth. So we're always stuck trying to appeal to the moral issue at hand. And I would want to, I liken it to, I wanted to do oncology, so end of life or palliative care. We never asked the question, is this saving money? Is this cancer drug saving us money? The question you're asking is, are you easing suffering and helping people out? And I want to argue, we do it, all of us that are doing this are really getting involved in the lives of people, minimizing what suffering you can and recognizing some things you can change and some things you can't, but you can be there with your patients. But that's not a money argument. And what I do is I step back. Here's a thing too. My wife, Jill, who's one of the pictures, after she's a PA and she went back to school to get her MPH when she was in her early 50s, right? And when she was finishing her PhD and she was studying homelessness at Harvard School of Public Health, she wanted to continue studying homelessness. And you know how many faculty members at the School of Public Health at Harvard study homelessness, which I would argue is one of the more pressing public health problems in the country? Turns out it's zero. And so our federal government does not fund studies like this. You have to do studies on cancer, or smoking, or something like that. But you can't look at, homelessness and put it against. So we're making a huge appeal. There's no academic program that's funded enough unless you've got some $30 million from a private source, but there's no easy way for you to do that. And we're desperately in need of these kinds of studies. Housing is a thing I didn't get into, but there is no real study yet that shows that even housing someone saves money or improves health. Believe that. But we know it must. It just isn't studied longer than maybe 6 months or a year. So we have there's a lot of, I would urge it, a lot of challenges out there for things we should be doing to come to that. And in the end, I want to say, I don't care if it costs more money. This is what we need to do to take care of people.
Unless somebody slipped a hallucinogen in my water earlier, I don't think the bean counters today are of the same ilk as they were maybe years ago. I think we all have a moral compass and we all want to do the right thing. And so not to be critical of that comment, because I think that is the experience that we've had, but I think we're coming across a new genre of administrators that really have a heart and a moral compass. At least I hope so, certainly here at UHealth. I think there's a question on the chat. If you want to unmute yourself, please ask your question.
Yes, hi. Dr. O'Connell, thanks for taking some time to speak with us about a lifetime of great work. The question I had was to ask about the goal or the endpoint, or perhaps the mission you're working towards generally. I mean, clearly it's to provide compassionate and comprehensive care. But I wanted to know if there were any other overarching goals that drive your work, such as, housing, relocation, rehabilitation, or reintroduction. And I'm asking from the perspective of working with the City of Miami's homeless division. They've got similar goals, but it's contained within the political priority of reducing the number or visible presence of unhoused individuals. And I'm trying to get a sense of if we can kind of aspire to your achievements given this ulterior motive or goal that we have. And if we have the same goals, what can we kind of gather from what you do given what our priority is or the perspective that we're coming from?
Yeah, and I appreciate that question, and it's a really tough one. I might answer it sort of obliquely by saying over time I've come to think of, and I would urge you to think like this. There are like two issues going on. One is, how are we going to end homelessness in this country? And the answer to that is you have to scale housing up to, the $1 trillion level, not to the $1 billion level. And we have to provide affordable housing. We're never going to solve the problem unless we do that. In addition to that, we're going to have to provide we're going to have to fix our schools. You have to fix our inner cities. You have to fix our correction system because they're the ones that are feeding homelessness down the line. So that's what we have to all, I think, fight like hell for to change society. The converse of that, though, is there's an emergency system set up, which I think you're talking about, which I'm part of, which is how do you take care of the people who are out here? How do you provide the best care you can to people that have been devastated by whatever has happened in their lives? and almost never by personal faults. It's almost always institutional shortcomings. And when you start to take care of them, you're in a different world. You're not ending homelessness. You're taking care of people. And it's very hard for politicians to see that. They're expecting you, if a mayor has an emergency system out there, they're looking for an immediate cut down in the numbers, which is not really what we're geared to do. We're an emergency response system. What we're really trying to do is focus on the long-term stuff. And since mayors are only elected for a year or 2 or 3, they can't look at those long-term goals. They have to look at what can I do in the next year or 2. And every mayor suffers from that. That's not a criticism of mayors. That's what they do. But I would urge you to think of, our job is really to figure out better ways to take care of people who are stuck currently in their, like, just think of this, LA, where I've spent a lot of time, has 47,000 people living on the streets, 47,000. And it's going to take years to house those people. And while we're doing that, there's going to be new people that come onto homelessness to fill their spots. So by housing them, we're not ending homelessness. We're only taking care of the people that are there. What we're trying to do is both. So it's a both and I urge mayors all the time to say, think of it in 2 ways. We want to go out there and take good care of people, but we want to work like hell to stop it. But don't make us responsible for each other.
Thank you very much. Thank you, our illustrious speaker. Thank you, the Global Health Institute, for sponsoring. I would like everyone to know online that there's the link for the MOC and the CME credit. As you leave, you'll also see a Rorschach test for that as well. And we'll see you all next week. Thank you very much.
Thank you so much. I appreciate it being here.